training as engineers. And the first time I actually saw a beating heart with the open chest, it was almost like a spiritual experience. And then I didn't even know what a PA was at the time, I must confess, after promoting PA week. But the person who was actually harvesting the saphenous vein from the leg was a PA. And I was like, well, what's a PA? And so I was like learning about this. And I just came to the point where I decided if I'm going to be working my butt off, I would rather, help people who need help as opposed to helping a greedy corporation. So in my 40s, I went to PA school. Fortunately, I had a nice husband who was also a chemical engineer who was working and helping. Also, if you ever do make big decisions, it's like amazing how the universe will guide you. It's just, amazing things will happen. So I decided I wanted to work at a community health center where we take care of uninsured and Medicaid patients. And so I've lived in Boulder for the last 34 years, in Kenosha Springs the last 2 years. But in Boulder County, I worked at a community health center for 17 years, taking care of uninsured. And that was really eye-opening, how it just breaks my heart, we have to work extra hard for the people who didn't have insurance because a lot of specialists will not see uninsured. And in particular, the orthopedists, I don't want to bash orthopedists or anything, because that's, expensive procedures, but they were some of the hardest. Like I had this one woman who, fell, she was a cleaning woman, fractured her forearm, and it was like bent this crooked. And there was one orthopedist who would consider our patients, but he wouldn't take the case. So it broke my heart putting a cast on this crooked forearm. And when it healed, it was still crooked, and she was in a lot of pain. And I called the orthopedist to say hey, what can we do? And he was just really recommending physical therapy. She's got to get it moving. And thankfully, we had a really good referral case manager who found a physical therapist who would take people for $35 a visit. So this woman was able to get physical therapy. She got some function back, but not a lot. Another sad story, I don't want to go into another orthopedic story. This woman, she was putting herself through college working as a dancer at a gentleman's club. And she was walking her dog, and somehow the leash got wrapped around her finger and clearly tore a tendon or something. So one of the nurse practitioners I worked with used to work at an orthopedic clinic. So she called this clinic, got this woman in, but then they never called her, and she never could get in. So she walks around with this weird deformed finger, which can't really be good, for her, work. So other stories, let's see. This was once there were a couple patients. I had a woman who got, she had a breast lump and it was cancerous, and she ended up having to take a pay cut so she could then qualify for Medicaid. Because if you're at 138% of federal poverty limit, you can get Medicaid. So, that was just kind of heart-wrenching. I had a couple patients like that. One, she had a really high platelet count. Platelets are the part of your blood that helps plug off a, bleeding cut, whatever. Really high platelet count. She was a smoker, she was obese, she had all these risks for maybe getting a clot. So she had to do the same thing. She had to cut back her hours so that she could then qualify for Medicaid. And she didn't really want to do it because fewer hours was less income for her to get things she needed. But then at the same time, I'm terrified she can have a clot or a stroke or something. But she finally got in to see the hematologist. But just seeing stories like that these people, they don't want to, if they work for an employer that doesn't have enough employees that's required to get insurance, or requires them to supply insurance, but then too many of these high deductible plans, you pay so much money to then still have a really high deductible. She didn't want to do that, so she was just getting by, and then of course something always happens. So I worked at this community health center for 17 years, and just became more and more apparent how badly we need universal health care. That people shouldn't have to suffer like that. just like, we have highways that everyone enjoys. You don't have to pay extra to drive on the highway, except there are some cases in Boulder, like Front Range, where you do have to pay tolls. But, and then after 17 years of that, what brought me to Pagosa Springs was I decided it was time to do something different. So I started working on the Hickory Apache Reservation in Dulce, which is like 2 hours from here. So some of our patients would actually refer out to Durango for specialists. And it was such a relief to know that if someone had a serious problem that required specialty care, I could refer them to a specialist. Because Indian Health Services, essentially, they get everything covered. And some of them, like they had New Mexico Medicaid, so that would be their primary insurance. But some of them, what was interesting too, was if they worked for the tribe had the most amazing Blue Cross Blue Shield plan I've ever seen. They paid next to nothing, everything was covered, and you could refer them anywhere, and they would like get to the front of the line. So that was, it was nice to see, but it was a good experience. I enjoyed working on the reservation, learning the culture, learning just some of the attitudes. I don't want to say attitudes, kind of a negative connotation, but learning some of their beliefs. You really have, as a white person, I had to work to gain their trust, or just gain their trust. But it was really rewarding when you did gain their trust, and then they tell you stories and you learn about their culture. It was very interesting. It was also some of their I'll never forget this one patient who, a lot of the Native Americans have diabetes, and they have this distrust of white people's medicine. And his belief was that his uncle ended up had kidney failure, ended up needing dialysis because of the white people's medicine, not because his diabetes got out of control and ruined his kidneys. So it was just, you really, had to work with them. But it was an interesting experience, and a wonderful experience. I really, got to know a lot of the people there. So it just certainly reinforced my belief that, everyone deserves to have coverage and equal coverage. So I guess that's my story. So any questions or anyone? I'm happy to, if anyone has their insurance nightmare story to say, or a lack of insurance nightmare story to share. Because I'm not totally happy. Like when I was not working at the clinic anymore, and I was independently contracting for 2 years, and then I had to get my own insurance, and the cost and the deductible is just a mess. It's just like, and I'm pretty healthy, so I'm like, I know I'm not, unless a disaster happens, I'm not going to use this. And it just was like, gosh, I'm just throwing this money away, but you never know. So anyway, so if anyone has any questions or has a story to share, I'm all ears.
So the clinic in Boulder?
It was an FQHC, so a federally qualified health center. So we got some federal funds, state funds. Boulder County tends to be very sort of generous in terms of, funds. And then we have private funders. So we, it was just kind of hit and miss, depending. We definitely had to work hard to see more patients so that the clinic could break even. But it was a good, it was a good place to work. Because I've never stayed anywhere 17 years.
Does the Indian Health Service rely on physician's assistants or medical assistants to deliver care?
Everyone's different. When I was the first PA they hired, it was all physicians. And then after that, they hired another PA, and he actually wasn't contract. They hired him, as a regular government employee. And then they had a couple contract nurse practitioners. It was a hard place to work. They had a lot of, pretty serious health conditions and a lot of alcoholism. And so it was like, had I not worked for 17 years before going there, it would have been, that experience was
So as a PA, how much time did you spend trying to deal with insurance when you were in Boulder?
So at the community health center, you know, there were very few insured patients. So our billing department, like I treated everyone equally, gave them the same care. And it was just a relief, like, oh, you have insurance, I can refer you for this serious problem. Whereas in Medicaid, not all specialists take Medicaid, but we did have a referral case manager who, you know, we would just grab her and she would put the referral, you know, we would write the referral paperwork up and she would send it off to, you know, we had a whole list of people that would accept. So, but and then at Indian Health Services, it was, you know, again, like, I didn't have, like, I would be aware of what insurance they had, so I could be like, oh, she has the tribal insurance. This is great, because she has a serious problem, we wanted her to get in quick. Because otherwise, sometimes, you know, someone who had Medicaid, if I was really concerned about it, I would have to call the provider to see if I could get them bumped up on a list. Because some providers, they will only take, you know, X Medicaid patients a month. And so, again, that sort of bothers me that there's this tier, like everyone should be treated equally depending on the level of their illness or, you know, condition. And so to see this tiered system always sort of troubled me.
All right.
If you could slide that phone over.
Thanks. Yeah, I'm Adam Owens. I'm a medical doctor. I've been here in Durango about 10 years. I showed up here working for Mercy, at Mercy Family Medicine, both at the hospital for a stint, at Bayfield for a stint, here in Durango. I did hospital medicine during COVID. So I've been, and then occupational medicine for them as well for a period. And that I showed up at a pretty nice time where they were hiring doctors and, hey, we'll cover everything. You just go do your thing, see patients, you know, and be a helper. And then it got to, well, you know, you can see some more. How about you see more patients and more and more? And I was doing about 30 in a day by the time I left a little over 2 years ago. And the patients I was seeing at that time were those who are, you know, are fortunate enough to have health insurance through their job, poor enough to have Medicaid, or old enough to have Medicare. And if you didn't fit into those groups, tough. And you know, here's our rates to come in and see Dr. Owens. About, you know, more or less 10 times of what I would see in my paycheck is what the patient would be charged. And ironically, about half as much as the insurance companies would be charged for me to see the patients would be your cash pay rates, essentially. So it's certainly not universal coverage. It's certainly not fair, and not even something that really made sense why one person would be covered and one wouldn't. We've kind of talked about that already. That grinds at you as a doctor, especially when people don't come back to see you to get their issues taken care of appropriately because of the cost. Particularly when you bankrupt people or send them to collections, which I've done numerous times working with Mercy and all. You know, and the economics of all this are absolutely crazy. In the 70s, you know, less than half of healthcare coverage or healthcare expenses were paid by insurance companies. Now it's, what's the number I got here? About 72%. And that has created this, there's not a lot of healthcare services that are affordable outside of insurance anymore. You want to go ask what something is, people can't even tell you. I never knew what anything costs that I've ordered or instructed my patients to do. Health insurance, it really isn't insurance, it's a health plan. It's not insurance like I have for my vehicle. I don't expect my insurance company for my car to change my window wipers or put gas in my car. But when it comes to primary care, which is my specialty, your family medicine, that's what I do. I do your maintenance and service. And there's no reason that needs to cost thousands of dollars, because it doesn't. But because it's been clumped into healthcare, now it does. That has to do with insurance. Nobody's paying for anything directly. Costs start going up. You know, if you're a CEO of an insurance company, you make X percent of what you bring in and pay out, and healthcare costs go up. Awesome. I'm making X percent of 10 billion now instead of 9 billion, right? So there's not a lot of cost control going on, which is why we find ourselves in this situation. The other, you know, so looking at that and being burned out, doing that to patients and working in a system and seeing so many, I got my loans paid off, which was part of my longevity with Mercy. I was on a loan forgiveness program. It took me all of 7 days to resign without a plan, and spent the rest of the summer selling firewood. Time to go back to work. I was looking at various tribal positions, one which I'd accepted and eventually fell through. And I remembered at that point, a year prior, when things weren't going well at Mercy, I had gone to Fort Lewis and taken some business classes, and I had in my pocket a business model for something called direct primary care. They had helped me work out the model, the plan, how to do this, because I knew nothing about that, right? I majored in public health and Spanish and studied medicine. So in contrast to the system that I was in, I started Durango Primary Care, which is not, and it's on my notes here, and it's underlined, but you'll love this, it's not concierge medicine, which grates at me, because concierge medicine makes me think of private jets and fancy people. And if you walked into my clinic, you would hear a lot of Spanish, and you would see a lot of people that you would not expect to be in some sort of bougie office. Concierge medicine charges a lot, charges your insurance. They do executive physicals, which is a whole bunch of tests for not a lot of information. You know, it's basically, it's what I do with a lot of smoke and mirrors and a mint on your pillow at the end to make people feel a lot better. But what direct primary care does take from them is the model that if you charge patients for their health care, again, we're talking about gas and windshield wipers here, basic stuff. If you charge them and it goes directly to the clinic, suddenly the costs are manageable. I charge monthly between $40 and $109. Actually, right now it's $99, but it goes to $109 in January. So full disclosure, $109 is the top, based on age, and that's a monthly fee. Patients can come in and see me once a week. They can see me once a year. They can call me, text me, email me. I've made home visits. We open the clinic on Saturdays for throat swabs and sutures and things like that. What do my notes say? So people who are seeing me now, right? I mentioned the Medicare, Medicaid, private insurance. I still have a bunch of those folks for the most part. Medicaid's a little asterisk there. We don't need to get into it. But who I also now see are people who are not insured. You can imagine this is a pretty good idea for them. People who are underinsured, have kind of insurance plans that don't cover much, particularly folks with high deductible insurance plans. A lot of people who are self-employed, small businesses. I also contract with some businesses here in town. For example, there's a large daycare, preschool here in town. Those employees are required to have a doctor's visit once a year. Most of those employees speak Spanish, and most don't have insurance, and it's not provided. So that company pays my clinic to be the doctor for these people. We do their annual visits, but I also take care of everything and anything else that happens in between. A lot of illness in the daycare. A lot of other businesses that can't provide insurance plans, as they are health plans, will cover a direct primary care plan for their employees. I like to joke, I've got a church and a marijuana dispensary and a liquor store and just about everything you could possibly need. For folks who are sending their employees to us because they want to provide something for them. A good primary care office can usually take care of about 80 or 90% of your healthcare needs and keep folks out of the ER and hospital by taking care of them in the clinic. For example, just in the last week, a large laceration on an arm was taken care of in my clinic, and an abscess drained, which would have been several $1,000 bills in the emergency department. Those patients paid nothing, in addition, aside from what they pay to have a doctor. It's good for me. It's a lot more quality. Instead of having 2,500 patients calling me their doctor, I now have 500. My visits are all 30 minutes to 60 minutes. I see 12 patients in a day, probably call another 6 or 7 to talk over things and send some more emails and messages to the other patients. I'm available if a patient needs me. We always have room to work people in because I have 30-minute appointments. Next day, same day, that's all around. If you're aware of the primary care issues in here, I can get a new patient in next week. Probably at the end of the week though. Let's see. We offer 2 other things that I think are really helpful for patients, and that's wholesale and direct pricing on lab work. I can usually get a patient set up for their annual health maintenance type physical by doing some lab work for around $12. And we keep about 70 or 80 medications that are generic in our office, and those are pennies. We'll specially order things for patients if they need them. It's amazing, someone goes to the pharmacy for a $50 prescription that I can fill for $5. That is really, really common. It benefits me. The traditional primary care doctors are some of the most burned out physicians that we have. That's one of the reasons why we don't have a lot, and particularly here in Durango, it's the burnout rates between, I wrote it down, 63 to 70% in 2022. There was a small survey among primary care physicians who are engaged in direct primary care practices like myself, and it was well under 10% who were burned out. So it's kind of nice when your doctor's smiling when they come in and they know your name, right? And so we've been able to provide that in a way that anybody who can spend probably less than their cell phone bill could achieve. So we've made that achievable for everybody, and the clinic has stayed alive. It's also very local, right? You pay your insurance money, 80% of that comes back to your health care, 20% stays with the insurance company. So a lot of that's leaving our town. When we pay Common Spirit, who owns Mercy, your hospital bill, for example, only about 10% of that goes to your physician, and another little bit of percent, maybe another 10 or 10 plus, is going to go to the other people who are working around them. The other 80% is gone. It's in Chicago with Common Spirit, who knows. There's some criticisms of direct primary care as far as what I'm doing. One of them is equity. I hope I've made a case that I don't believe that's true. I think I am far more mission-based now than I was working for a non-for-profit. Honestly, I give out more care than I did as a non-for-profit. Mercy gives about 1.5%, or Common Spirit gives about 1.5% of their revenue to charity care. And I look to see who in my patient group we are not charging for one reason or another, and it was just over 2%. But I'm for profit and they're not. Go figure. Let's see, and then a primary care doctor shortage. I went from taking care of 2,500 patients to only 500 now. And so one of the other criticisms is, well, we're taking away doctors, you're not doing as much, you're not seeing as many people, and you cannot take care of that many people in a way that makes sense. So what would I do when I was at Mercy? What did all my colleagues do? We'd refer out, we'd send them to other places because we didn't have the time to deal with that. I am doing the work that I was doing there for my group and kind of tending my garden and taking a lot else out from the other clinics here in town. I'm also a clinical professor with the University of Colorado with the School of Medicine at CU. And so I'm exposing medical students to this, and primary care and family medicine right now for most people in a traditional system is not tenable. And what I'm doing is, and if we can convince the newer generations of physicians coming up that it is, the primary care shortage will be gone, because what I'm doing is far better than any specialty that I could ever imagine. So that's it. That's what I do in my journey in a nutshell, and how it relates to you know, probably not universal, but certainly more equitable healthcare. Yes, ma'am.
So are you the only provider?
Yes.
And how big a staff do you have?
I have two. It's changing. I have 4 people part-time. I have about almost 2 full-time positions helping me with the job.
And do you see, what's your patient age range?
Cradle to grave.
Really?
Yep. So we do pediatrics and all the way up to hospice care.
So if somebody, let's say a Medicare patient, obviously you don't take it, but do you have to refer many patients to, God forbid, Mercy or Ash or something? And Ash is fine, but Mercy is not.
Yeah, contrary to what some of my patients believe, there are things I can't do. And so and I can tell you, I had an uninsured patient who came in with something on his neck that was about this big. It was my suspicion was some deep tissue infection and abscess, and that's what it was. And when I broke it to him and said, hey, I gotta send you to Mercy. You need a CT scan and an ER where a doctor who can review that and a surgeon that can take care of it. This guy, it sticks with me. It was a year and a half ago that I did this, but just the deflation I saw in this patient, he was uninsured, was pretty heartbreaking. He hasn't been billed for the last year by my clinic, actually, in fact, because this got him into financial trouble. But that happens with some, periodically. Yeah, I have to refer things for specialists because I need their help. My patients who are insured, we use their insurance. I play those games and we get them in. If you're not insured, well, we talk about what's best, and then we talk about what I can do, and then we try to hammer out what's going to work.
So what happens when you have 500 patients now?
Mm-hmm.
What happens when you hit more?
We grow. There's a lot of unsatisfied primary care doctors at Mercy, for example. I don't think, so once I have room, it's going to be very easy to grow this practice.
Okay.
Yeah.
Just as a comment, there was an example, I left the States for New Zealand in 2009, but it was really common in those days, for patients to have a $10,000 bill for a 6-hour ER visit, because you have to do scans and you have to do this and you have to do that. And I always thought you should drive that home, not go home and figure out how you're going to try to pay for it. Sorry.
No. Yes, sir.
I don't know too much about or anything about medical system, but would you say, I guess Medicare is a single payer system? Yeah.
After a fashion, yeah. I think of it as an insurance company. When I'm dealing with patients, they sure act like it, and they don't pay for everything, or at least willingly.
And I guess this whole program is trying to advocate single payer. In the times I've gone to, not all of the, some of the doctors would say to me, in fact, one of mine that left Wellington Medicine, he said, I don't mind practicing medicine, but it's the Medicare paperwork and all that I have to deal with.
There's a problem, a long-lasting problem with Medicare, and that is that Medicare wants to limit the amount of money that they pay for a given condition. and they're up against doctors who are very good gamesmen. And we know how to play the game.
Yep.
And if Medicare says, well, we'll only pay you $15 for this sprained ankle business, but if you do a complete examination, like a history and a social history and a family history and this history, and you document that, then we'll pay you $100. Well, guess what? Doctors do all of that stuff even though it's not necessary, so that they can get reimbursed. And so the system has gone through this circus of, we don't want to pay you very much because we can't afford it or whatever, because we're not funded that much. And so we're going to make you play these games. And they're up against really good games players. But that's why doctors are burning out. They don't want to play games. They want to take care of people.
Well, that doesn't seem to take a great deal of brain power to realize, isn't there somebody in Medicare that has been in the practice of medicine that has done that and realizes that and does something about it? I mean, doesn't everybody want good, efficient, effective medicine, medical practice?
No, they don't.
But the problem is underfunding. If you're only going to take care of a certain small, and you want to take care of a small portion of the population, and you want to do it as little as economically as possible, then you're constantly excluding this or that, or putting all these conditions on it. If you actually have a system, which we don't have a health system in this country. We have a bunch of individual providers who are milking the system for as much money as they can get. And there are lots of highly moral practitioners that don't really want to be a part of that, but are forced into it. And you have various solutions.
So I have a question.
Yep.
Do you have patients that say like, oh, it's time for my annual exam, I'm gonna pay you this month and get my annual exam, and then I'm gonna drop
And
it?
then bail? Yeah, or I'm sick and I'll pay my 1 month, you know, I'll pay you $40 and then I'll bail. Yeah, that happens.
It happens.
We make people pay $60 to register so that we're not so much of a stopgap coverage.
Oh, I see, so every time they
Uh-huh.
come, you re-register.
Yep, and I can, and you get a sense of it when a new patient comes in, what they're after, and then I say, you know what, hey, I'm getting $100 to take care of this guy's sore throat, I'll take it, and and then they're on their way, and we haven't had any try to come back yet for a second, and they'll find it hard. I don't want to do that. I'm not an urgent care. I want to have patients that want to have a doctor, and that's really the larger issue. You can't take care of people in primary care. You just can't take care of people episodically, and that was the whole problem with a fee-for-service situation where you have insurance. What I do, how do I charge for the phone call about your lab work, or the paperwork here, or the daycare form I filled out, and the camp sheet I filled out for them? None of that has a bill attached to it or anything, but it's all important things that I do that you resent doing for free, just a little bit, particularly when you're back-to-back patients all day long. And so we've just built that in. I'm just your doctor. When people call me on the weekend, the first thing they say is sorry to bother you, and I just always remind them, this is what you are paying for. And here I am. What do you do?
The big difference for me in New Zealand was that patients would come into the emergency room and say, I'm so sorry to bother you. And then they also said, thank you.
Yeah. Doesn't that feel nice? Yes, ma'am.
So how do you prevent your own burnout?
I'm doing it. I can do
You
this.
can't do it 24 hours a day, 365
On call's not. I am energized when somebody needs me and I can help them. I really am. That's not. That's why I did this. And so often in traditional practice, people need your help and you can't do anything. Your hands are tied. People wouldn't know how to reach me. So when I get after hours calls a couple a week, and on the weekends, and that's.
But you have to take a vacation. I mean, you have to.
That's when I grow and add another person and so on. So yeah, going on 2 years, I'd love to be a little bit more free, and that'll happen. But at the same time, I had a patient call me from an urgent care. Their daughter had a broken thumb, and they were selling them a $300 brace for this thumb. And I said, snap me a picture of the x-ray, and they did, and I said, you can get that at Walgreens. I know exactly the brace for that kind of injury, I'll tell you what it is. The urgent care PA was not happy with us, or me, or the patient, but I don't care. So stuff like that I'm proud of, and I feel good. I feel more of a calling now than I did, rather than a 9 to 5. And that is why I went from being one of those 60 to 70% burnout physicians to, now in this group where we hardly have anybody, and I'm certainly not one of the 10% who's burned out in direct primary care. Yeah, the call is it's a small issue, smaller than I ever thought.
Given the levels of burnout and all the conversations here, what are these conversations like within the medical community? Is there a lot of conversation about changing or moving or doing things like you're doing or whatever?
All the time. I mean, complaining about Mercy is a local pastime here among the doctors, but as far as and I was involved my 10 years with Mercy. I was involved. I was on our physician leadership council, and I did everything I could to try to help, and eventually voted with my feet. I'll let everybody else talk, but that was my experience.
I want to make one comment about the word burnout. The subject came up a lot at our community health center, just because you're seeing a high level of complexity of patients. You need to see X number, 15 minutes, go, and then at the end of the day, you finish your charting, you go through all the ER reports, you get all the paperwork, all those student forms you need to fill out, FMLA. Those FMLA forms are horrible. They're like 6 pages of torture. And so the correct term and this is not my word, it's moral injury, because what's happening is that you're being put in a situation where you want to do the right thing, but you're not given enough time or enough resources. And if you want to do the right thing, you end up doing it on your own time, and that's what really starts to wear you down. And so, because burnout implies you're the weak person, whereas moral injury is what the system is doing to you. So, just
Sorry, good point.
wanted to mention that, but that came up a lot in our, community health center.
Burnout was a huge thing for emergency physicians, and still is. The average career for an emergency physician is 15 years, and then they're done because they just can't handle the system anymore. I did it for 45. But my last 10 years in New Zealand was career saving, because I was able to actually take care of patients that needed me. Almost all of them needed my care, and I was able to get referrals, and the system worked. And that was an amazing experience. We're taking all your time.
I just am a little discouraged. We talked about the burnout. I'm a school teacher, so I probably have a little idea what that is. But when I said, don't we want effective, efficient medical provision in our country, and we had a lot of people said there are people that don't particularly care to have that. And that's, for me to hear that, that's very discouraging. I mean, wow, no one, and excuse me for saying this, but no wonder, people, when you hear that from medical people, you kind of really get discouraged with the medical institution like we have with a lot of institutions, and no wonder Trump's getting certain people to vote for him. Just what they want, that's what they're, and here we say, yeah, we don't want effective, efficient
Capitalism
Pardon?
It's capitalism and profit driven. And
Well,
that's the problem. There are some things, in my view, that should not be just capitalism. It ought to be, I'm what you might call a democratic socialist. I think that things like policing and prisons and education and healthcare should be publicly in the public domain, and they shouldn't be for profit. And profit destroys the system. And
Although I would add that the profits are being sucked up by our local non-for-profit. The Common Spirit CEO raked in $35 million in 2022. The Common Spirit CEO had $35 million. That's 100 primary care doctors over the course of a year.
yes, he said money.
It sure does, yeah. It would have, yeah. So, but yeah. So you know, nobody wants bad healthcare, but yeah, it's how you pay for it and where that money goes, where this all goes sideways.
Sir, I would throw out a response to that concern, and it's a very valid concern. And that is to seek out people who are innovative and who are actually doing things. Because believe me, many in our profession are pissed off, embarrassed, chagrined by the greed that drives our system. I mean,
I'm sorry there are not more young people to hear that today, here with us.
but that's
Hey,
true about
we've got-
having a teaching position.
Yeah.
And giving to medical students so that they don't go into orthopedic surgery, you know, for the $750,000 a year position, and might be a little bit more humble and say, I want to render service to the people around me. I'll pick it up from here. And, you know, I retired 5 years ago from practice here in this community. And so I am going to wax a little more philosophic, because you guys have covered all the dirt, the hard work, the grunt work. I had a little bit of a unique career. I started medical school when I was 30, and I went to a medical school in Brussels, Belgium, that celebrated its 500th anniversary, the second oldest in Europe, the year that I went there. And so I spent 6 years in Belgium as a student, and then came back to the States. Did a year of internship in Spokane, and then did the remainder of my family's practice residency in Santa Rosa, California. And then I've been in private practice until I spent 4 years in Pagosa in a private practice there, and then came to Durango, worked for Mercy for 3 years, then worked for the urgent care, and finally for Access. And it was an eye-opener to work for Access, and I'm not going to spend a lot of time throwing rocks at Access, but bureaucracies are bureaucracies. I mean, I don't care, you know, how you pronounce them or how you paint them. They're driven by the buck, and they're not inspiring. What struck me when I came back from living in Belgium for 6 years, we were mandated, and my tuition was really nominal, because most European countries, they will take graduates of their high school and accept them. They don't have entrance exams. They actually do a winnowing out over years, so you get in and you pay nominal tuition. Healthcare is mandatory. My healthcare bill was about $400 a year. And so I went through medical school under a socialized medicine, dirty word in this country. But it was a very well-structured program. It's really very interesting. When I look at how the United States has managed to remain the only industrialized country in the world that does not have some form of organized medicine. So everybody else has socialized medicine and we don't. Why? Well, Europe, after World War II, you know, it was ruins, you know, the economies were shot. And so those countries, Italy, Spain, Germany in particular, England, they set up systems that they could budget for, that they could actually say, we can render care to our crippled veterans, to our widows, to our orphans. So they were forced by economics and by World War II to structure these systems. And they're very interesting to look at. If people have not read this book, a book by a guy named T.R. Reid, R-E-I-D, The Healing of America, this guy spent 5 years of his life living in 5 different countries and studying their healthcare systems. Singapore, Italy, Canada, Germany, yeah, and went through, and they are all socialized medicine countries. and it's fascinating to see how they came about. And there is no template that they have followed. They each is unique to that country. And when we as the United States try and figure out a system, it is not to, steal their program, but to use it and learn from their experience, because they all have been burned and, they all have evolved. And so what has stuck with me from that book was that at the end of the book, there was a statement, and I can't remember by whom, but it was that until the citizens of the United States do not believe in making a huge profit from medicine, until they give up that idea that this is a way of getting rich, be that doctors, insurance companies, durable medical good, pharmacy, until they give up that notion that this is okay to gouge people and make tons of money, we'll still have the same system. And there will still be kickback and anger and fighting back from all of the entities that I mentioned, and not excluding doctors. I mean, there are a good number of specialists, and I hate to throw rocks, but specialists that do not want to see this system change. Even in these difficult days of COVID and everything like that, there are plenty of specialists that if we were sitting up here and talking about some economically reasonable way of rendering medical care to our citizens, that would be there dug in and with all of their rationalizations and all of the, I have to say, when I was going through medical school in my 30s, I called up an old Army buddy of mine. I said, "Hey, Richard, I'm going to medical school in Belgium." He says, "Good." He says, "And I'm going to tell you, my friend, from North Carolina." So he had a unique way of phrasing things. And he says, "Tell you what, son, if I ever hear you say that you had to go to medical school, I'm going to kick your ass for the rest of your life." Nobody forced us to go to medical school. And I hear this whine, "Oh, it was so expensive, I sacrificed so much." Didn't have to, sucker. You had a choice. You chose it. So, sleep in that bed. You made it. And don't have someone else pay for it. But anyway, back to T.R. Reid. It was fascinating because he hit it right on the head. As long as people, to me, it's fundamentally immoral to benefit greatly. Not that you shouldn't be able to make a living doing medicine, but to benefit greatly and disproportionately from the work we do. Because that's the capitalist mantra. Make as much as you can, and it's something that I don't know. It's hard to sell morality. not a big market out there.
My personal experience was when I was raised pretty poor, and I only had a family doc, and that was the only doctor I knew until I was in medical school. I had no idea what doctors made. I figured I'd make a decent living, but I didn't think I was going to get rich. But there were people in my class that knew they wanted to be ophthalmologists because ophthalmologists make a shitload of money.
Well, it's really fundamental in our culture, and I saw the medical care that I got in Belgium, and I didn't have many medical problems, but when I did, there was no question. You go to the emergency room, or you go to wherever you choose to go, and there's no question. There's no wallet biopsy as you walk in to see where the money's coming from, and that's happens a lot in this country. Wallet biopsy, how much money can you pay? I have an Italian response to that. None of your damn business. It shouldn't matter. So it really is very interesting. Also, another thing, when I was practicing, I went to a couple of OBGYN conferences. I delivered lots and lots of babies for lots and lots of years, and I just really enjoyed it. And we had an American call, the AAFP conference in Toronto. And so we were up there and we had numerous Canadian doctors speaking. And I went up to one of the OBs and I said, I'd like to talk to you about how your system works up here. And I said, and he said, glad to. He said, but I have to tell you something before you tell me much. I've had that question asked of me many times. And he said, and I can tell you that the criticisms of the weight, and there are many criticisms of the Canadian system, it's not perfect. But he said, the information you get a lot of in the United States comes from disgruntled Canadian doctors who have moved to the United States and are making lots of money down here. And they are delighted to rag on Canada. They're the ones who have stayed. If you look at surveys, World Health Organization surveys for that matter, that measure the satisfaction of the population, a representative sample of the satisfaction of Canadians with their healthcare system and the United States with our healthcare system, far more favorable in Canada. If you step back from it and you're not advocating for a position and you just say, okay, what are the numbers? In general, people like their healthcare better in Canada. And one of the points that you made was really interesting. One of the things that, my Uncle Roscoe lives in Vancouver, and he had, a bad knee, and he had to wait 6 months for the surgery. And exactly what you said, many of those people who were scheduled for surgery, when it came time to lay down on the bed and have anesthesia given, they go, I don't think I need that. And there's a benefit to that rather than rushing in and saying, well, we've got to fix it now. And they lean on a lot of other modalities to help people function without surgery. So I came back with a chip on my shoulder from living in Europe, and I look at the United States in many ways as arrogant, narrow-minded, xenophobic. Like we when I was in Pagosa Springs, my partner over there said, you're brand new, you don't have a practice built up yet. You want to go and talk to a group of citizens? Sure, bring it. I said, on what? He says, on improving our healthcare system. I said, sure. Who are they? Oh, it's the Republican Women's Club. And I had information from the World Bank, the World Health Organization, and it showed many of the flaws of the system. Not that I wasn't throwing it under the bus, but they were absolutely appalled at me, and they said, well, you can lie with statistics. And I'm going, wait a second, I'm not selling a product here, what the evidence shows. But we United Stations are very, very invested in how superior we are. And I don't need to cite any proof of that. It's pretty narrow-minded. So that's another thing that happens when you try and change the medical care system. Oh no, everybody knows that ours is the best. I don't know.
Nobody in the rest of the world thinks it is.
They don't. Absolutely not.
One of the things that tell me if I'm interrupting inappropriately, one of the things that people don't understand in this country has to do with medicines and formularies. In New Zealand, there's a thing called Pharmac, and they have a board of practitioners who select the medications that are going to be allowed to be sold in New Zealand. And if your medication gets on the pharmacy, on Pharmac, then when a doctor prescribes it, you get it, and the cost doubled while I was there from $3 for a month's supply to $5 for a month's supply. And actually, it was $5 for 3 months. And I was appalled when I came back to the States and realized that people with asthma are paying $100 for an inhaler.
Generally, for a controller, it's
okay.
300.
300.
Yeah.
I can give people, they can get 3 of them in New Zealand for $5.
might you
So,
float into?
the thing that they don't have in New Zealand is no advertising for drugs on TV. They also don't have Me Too drugs. An awful lot of the drugs that are sold are modifications of certain chemicals that mimic the effect of the original drug, and then they try to convince you that this is worth 3 times the cost of that original drug that's now generic, because you only have to take this once a day, and that one you have to take twice a day. And we all know that patients hardly ever get their second dose, they only do it once a day. So you can justify this payment, and it's actually cheaper because it's a convoluted argument. But one of the classic things is in America, we socialize development and we privatize profits. And so a classic of this is the EpiPen. Many of you know students that have to have EpiPens. It's a self-injectable adrenaline shot that you give for people with anaphylaxis. That EpiPen system was developed by the government in the 1940s. Adrenaline is generic, and for years and years and years, it was sold for $50 a pen. The cost to make it is probably in the order of less than $1. $50 a pen. The company that made it bought up all of the generic manufacturers and came out with their brand of EpiPen, and they were selling it for $500 a pen. And people really, really protested, and they said, well, you're right, that's too expensive, we should make a generic version, so we'll sell the generic version for $3.50. This was a drug that should be in the public domain because it was developed by the government. You guys, or my parents, paid for it. And then they allowed private patency to make a patent, and that's what happens all the time. In the United States, if you take Tylenol and Motrin and you combine it in a pill, and that hasn't been marketed as a combination, that's a new medication. You can patent that for 17 years. And you can charge beaucoup amount of money for it. I take a baby aspirin a day, because I did have some heart trouble, and I can buy 1,000 of them for $5 in Costco. If you get a prescription for the baby aspirin, you're paying $25, $30 for a month's supply. It's crazy. And so we have to get off the privatization of public medications. We develop them with the government, and that happened with Paxlovid and with COVID vaccines. I heard that Paxlovid is now being sold for $1,500 for a course of medications, and the government paid for that to be developed.
And their big like innovation for Eppies was that they designed this really fancy container. So it's just the plastic, like it used to come in with an oval shape. So it used to be cylindrical and come in a plain cylindrical little plastic container, which worked just as well, but they put all this R&D into this fancy packaging.
Well, my son, I gave him a boat and he was going to go live in the Bahamas for a while, and I thought, you need a first aid kit, and so I put together some adrenaline medications for him. I was going to get him an EpiPen, and that was when it was $500, and so I actually got some generic vials of adrenaline and some syringes and needles, and showed him how to draw it up and make it, and the right dose to do. And I think I had $10 invested in 5 or 6 doses.
That's what we do for some of our patients.
Yeah.
So we've given them a kit where I've marked the syringe and show them how to draw it up.
I like a kid like that because these hurt like heck too.
Still hurts.
This is like being kicked with a horse with a
Well, interestingly, in the military, I spent 4 years in the Army. We had a Surette that you would use if you were gassed, and this is quite in the 60s. And so we were taught how to use these Surettes that you would just go bam in your quadriceps muscle, and it worked just like an EpiPen, and that was in the 60s.
So
They
it's not
didn't
really
use that.
Yeah.
They created a whole other product
Right.
and can market it, and they actually they got such an exclusive, there used to be Anna kits and EpiPens and other alternatives, and now there aren't.
You said they bottom up, right?
Yeah, they bought all of the generic manufacturers up, and then they owned all of the manufacturing facilities, and they just
Bingo.
raised prices. I think the CEO of that company ended up going to prison actually, but he was a fine individual.
There was a guy, I think the guy who went to prison was for insulin or something.
Yeah.
A lot of
Was it?
CEOs.
Okay.
Well, in Durango, I've been in Durango for almost 40 years, and I've worked for physicians, billing insurance and management, and anybody who didn't work for Mercy, I was happy to work for. And I think what a lot of people don't understand, there's a handful of physicians in Durango who make a lot of money, but most of you don't. You know, you're not as wealthy as somebody from New York or Chicago or San Francisco. But the frustration is the middlemen who make the money, the PBMs and the medical equipment people and the CEOs. Like you said, it's absolutely, it's immoral. It is truly, truly immoral.
It is.
In one of the ways I'm still riding high after being on call 700 days straight is I'm not paying those guys. They're not making money on me anymore. And
Good for you.
I'm very proud of that, as you can see.
You sound really happy too, and you know, that, I really enjoyed my career in medicine, and I worked in big trauma centers, and there were times in my life when I saved somebody's life every 3 days. And that's something you can't feel bad about, but it's a terrible price to have to pay to work in a system that just doesn't serve the people that you're trying to help.
What's also frustrating is all those profits they're making are going to buy our representatives, senators, and it makes it just harder to change the system like the Colorado Healthcare Coalition is trying to do when we don't have that much money to influence.
And there are deep pockets.
Yeah, but we're getting better though.
Can I just ask two questions? Why hasn't the public jumped on this, and why aren't we 50 years ahead? I mean, you guys know all this, and I'm sure a lot of people in the public knows this too. What's the big drawback with the public? Why do they not advocate for single? And another question is, why not? Single payer. Why not just have everybody go on Medicare?
Well, single.
Same. When all this, you're doing all this for single
fear
payer.
of change.
Seems we could be.
Who's actually sick in this country? It's not the young in general. Most people don't have serious health problems until they're childbearing age, and then women have problems associated with, or medical needs at least, associated with childbearing. The majority of people, except for injuries, are really quite healthy. And when you get older and you're sick, you don't have that much energy to go out and change the world. And I think that that's part of it.
Fear of change. I know when I was working at the La Plata County Health Fair, we had a little booth there. We were doing a little healthcare game, and one of my favorite responses, I was asking, we were playing a game, would you like to play a healthcare game? She's like, oh no, I already have insurance.
Yeah.
But they all know how expensive it is. We talk to anybody about the premiums they have to spend on healthcare, and they're terrible. Well, guess what? We can do away with it. But even there, you say old. Well, I know a lot of young people. Three of them that were
Higher
even
taxes
40
is
years
one of the ways
old.
we pay for this. And,
Pardon?
we would pay for more healthcare and public healthcare with higher taxes, and we know what people like to do with that in the public sphere. That's a big no-no, right?
Well, but you're
All
paying
of
higher
healthcare
premium
is
for
paid by-
healthcare too.
Yeah.
Right, no, and I'm not saying I don't mind paying, I'm just saying that's a boogeyman, right, politically?
And look at all the people that don't have it.
All of healthcare in New Zealand is paid for by taxes. The tax rate that the average New Zealander pays is much lower than the tax rate paid by the United States.
Yeah, well, I mean,
I'd like to add something to what you said. Americans are being told that we have the best system in the world.
the best way.
And it's true, if you have some kind of rare cardiac thing, you're gonna find someone here who will charge you $50,000 a day to fix it, right? But our outcomes are not the best. And so that's not a well-known fact. That, sure, we have a lot of good spots, the Mayo Clinic, and Anderson, whatever, in Houston. But average care, we don't have the outcomes, and our maternal mortality is high compared to the rest of the world. It's, when you start looking at these things, you find out, but most people don't come, listen, and learn.
Another factor is there's a group of family practitioners in Durango who for about the last 5 years have been meeting and trying to address the horrible performance of Centura. And, you know, they changed the name, it's Common Spirit now, but it's the same band of hoodlums as far as I'm concerned. And they have a huge battery of attorneys, and boy, to make objections, you have to be very, very careful. They really have their coffers are well guarded, put it that way. And if you offer observations, desire for change, not gonna let you rock their boat. There's a lot of money that we found out that it was very, very, very hard to change in this county. Never thought that. I never thought that would be a big issue, but it is. And the inertia. You know, people. Oh well, I went to the doctor the other day and it was okay and wasn't great, but it was okay. So I'm not going to do anything. To change this system, there's a whole lot of inertia. Sad.
I'm sorry to hear that.
Absolutely.
So two of the big objections I've heard to universal health care over the years, apart from taxes, are that you would have to wait so long to get care, and then something about death panels, you'd be having bureaucrats deciding who would get care for their cancer and who would not. So what would your responses to those two objections be?
Okay, there's one of the groups I volunteer with, we have a person from Canada, and these long wait times, certainly for elective procedures, the waits are longer in Canada, but if it's something urgent or important, they get seen right away, and they're taken care of.
Which, and before you go on, I'll contrast that to here locally. I needed a gastroenterologist to do a scope on a patient, in the next 2 weeks or so, and it took 6 months. So, we're rationing. It's just all over the place. But go on, yes.
And then the second thing you also hear is, oh, well, people are coming here from Canada so they can be seen sooner. I think that's like 0.01%. It's like some really small percentage.
And very affluent people.
Yeah,
That's
yeah.
not the common person in Canada. I go up to Canada every year to go fishing, and I've been injured when I was out fishing, and I got very good medical care. And so it's I don't know who generates it. I can't find the boogeyman.
Well, it's all of the money.
It's just sort of
Well,
the
it
myth.
is.
Yeah.
I mean, I'm on your side in case you didn't guess.
Yeah.
It's just sort of the myth that you hear is that you'll have to wait so long and there'll be death panels deciding who.
Well, there's a lot of scare tactics,
Yeah.
and there's a lot of disinformation, and the people with deep pockets, it's to their advantage to misdirect us. I like the three guys sitting at a table, and one guy's got a platter full of hamburgers, and one guy's got 2 hamburgers, and this guy over here has got 1 hamburger, and the guy with the 30 hamburgers says, watch out for him, he wants your hamburger.
Yeah, that is so true.
And that's what the tobacco companies have done throughout their career in terms of misdirection. That's what the oil companies have done in terms of denying climate change, and now they're saying, well, let's just switch to natural gas because it's less polluting, like maybe. I mean, the it's a problem with capitalism, and I love this country, and I love an awful lot about it, but I really am troubled with the profit motive for everything.
And the
Predatory capitalism.
money in politics. If we could get money out of politics.
So
Money out of medicine.
what is the Colorado Coalition doing about this? Where are we now?
So, yeah, this has been, in my opinion, the best presentation we've ever had of the ones that we've done here. You know, obviously you're getting firsthand information from people that have been in the system and that are fighting back against profit and that sort of thing. The Colorado Healthcare Coalition is also working with some other nonprofits around the state. And we don't believe that it's possible at this time to do a national universal healthcare system, whether that's improved Medicare for all or whatever. It's just, there's so much money that people are making and are not willing to change and are not willing to even give up a small fraction of that money. So we do think that we can do something in Colorado. Colorado has been a leading state on some of these kinds of issues, and we think that that's possible. Now, it's not going to be easy, because still we know that the special interests are going to come after us. But we've put together a plan, and we're working on a strategic plan right now as to how we're going to do this. And the first step is to get a study done by the Colorado School of Public Health that would show how we could do single payer in Colorado. So single payer just means that there would be an entity that would likely be a part of the government that would pay everybody when somebody got health care. Okay, rather than you having hundreds of different places you got to go to collect money, there would just be one. Okay, and we already have a study that shows that we would save somewhere between $1 and $4 billion the very first year by going to a single payer system over what we have now. So our goal is to try to get something to the voters probably by 2028 to say, let's change this. Now, as you mentioned, there's all this misinformation that comes out. So one of the things that we're working on is an educational campaign, and we're literally talking about raising millions of dollars so that we can tell the people what's really going on and why these things are happening. Strangely enough, one of the things that's working in our favor is the price of everything keeps getting higher and higher and higher, and people are now starting to say, I can't do this. We can't keep paying more and more and more in real dollar terms. And medical care has typically gone up 3-4% above the rate of inflation. And over a period of a couple of decades, all of a sudden it's double what it was before. So we've got this plan going. We would very much appreciate your help if when you came in, if you gave us your email address, we'll make sure that we keep you informed. We want to do this study through the legislature. We think that there would be more credibility to the study if the legislature commissions it from the School of Public Health. Okay? Unfortunately, of course, there is no money in the budget, discretionary budget for the legislature this year. So we're still trying to get the bill through, but we're going to raise the money to pay for it. Okay, these different nonprofits around the state. And it's going to be somewhere between $350,000 and $700,000 to get this study done. Fortunately, we had somebody show up and join us a couple of months ago, and her job is to raise big dollar money. And so she is in a position where she knows who the donors are, she knows what the foundations want to do on it, because I'm actually quite optimistic that we can raise the money that we need. But I do think it's going to take somewhere between $15 and $20 million overall to educate the population. We may have to go out and get signatures to get it on the ballot, because again, it's what I'm hearing from the legislators is there's no way you're going to get a referred measure for single payer health care out of the legislature. Okay? If we can't, we'll go get signatures. That's a couple $1 million kind of deal, because you now have to get signatures from every Senate district. You can't just go sit up on the Front Range and get all the signatures that you need. But again, we have a plan for all this, and I feel optimistic that we can in fact get something to the voters in 2028. And some of it's how you phrase it. If you ask people, should everybody be able to get the health care they need regardless of how much money they have, you get a very strong positive response to that. Even on Republicans, it's about 50%, and among Democrats, it's about 70%. So that means 65 or 70% of the people in the state think, yeah, we ought to do that. When it comes down to, exactly how you do it, that's what we're working on. But again, the special interests are going to come back and they're going to say, you don't want socialized medicine, do you? And they're going to say all the doctors are going to leave because they're not going to get paid enough. And there's going to be all this stuff that we've heard before and we know we're going to hear it again. So we have to be prepared to be able to fight that tooth and nail, raise that kind of money. So at some point, if you're on our mailing list, we may send something out and say, please contact your representative, your state representative or your senator, and tell them to vote yes on this bill, okay? And then, we're gonna have fundraisers and we're gonna have to, get out there and we're gonna have to put our money where our mouth is in order to make this happen. So again, I feel optimistic that we do in fact have a plan that is workable. It's still gonna take a few years. The other good thing is that other states doing the same thing. You may not be aware of it. California has actually passed a bill for single-payer health care twice. And the Terminator vetoed it each time. Okay? So again, there's money there that you've got to, but they're still working on it. California's working on it, Oregon's working on it, Washington's working on it. I talked to Dr. Jarvis, who was the executive producer for the movie that we premiered we showed it last month. And they're working on something in Utah, and New York's working on it. So the feeling is that over a period of time, if we can get some states that implement this and show that it works well and it costs less money, which it would, that we can eventually get a national system. Okay, but it's going to be hard. We're going to have to fight like crazy to overcome the big money interests. When we did a presentation one time, I said, here's a CEO of a pharmaceutical company. He makes over $100,000. Not $100,000 a year. $100,000 a day. I mean, can you imagine? So, and that person's going to fight. And frankly, even if the CEO said, well, we need to cut our prices some, work better for the people, he'd get fired immediately by the stockholders, and they'd bring somebody else in who would do that. So, to your point, yes, we've got to get the people behind it. We've got to have the people understand what's going on and why this costs so much. And, we just can't continue doing this. So again, we have a plan, we're working on it, we need your help.
And Gwen, it's interesting, and this is from multiple sources, it is estimated that with no change in the healthcare system as it is now, it will bankrupt, it could easily bankrupt the federal government in about 7 to 8 years. The cost of medicine is going up so much annually that it really, if you look at the money to do nothing, it's suicide.
Yeah.
Well, yes, George Bush made it a federal policy that Medicare could not negotiate with drug companies about prices or anything. And that's carte blanche for the drug companies because Medicare actually is the biggest purchaser of pharmaceuticals in this country. So, some of the platforms are looking at changing that, but man, they've got a big hard road to toe because of all the deep pockets. And of course, we now have corporations that are considered citizens for your financial donations, and that makes you feel real powerful.
Well, didn't they pass a bill that they're going to negotiate with certain,
Well,
drugs?
the platform for Harris right now is that she wants to expand the negotiations. They are currently allowing negotiations on certain medications. Insulin is one of them.
There's 10. They're allowed to negotiate 10 right
10.
now. 10 more they can negotiate next year.
Well, that won't
But
come
out of
into
thousands of
effect.
medications.
That won't come into effect until 26. they're negotiating, but it won't come into effect.
Right.
But at least they're there.
Yeah.
That's a step, yeah, in the right direction.
It's, the system's rigged. Follow the money.
So before we have a drawing, everybody should have gotten a ticket when you checked in. But first, I'd really like to thank the panel. I don't think we gave you guys. A couple of gift certificates for Maria's Bookstore. And so we're gonna draw out two numbers.